results of it in the decades to come.
Yeah. No, and I think, I mean, where we're at, unless something's done, and we need to see that proper transformation in our health service. And it leads into, and you'll have heard a lot around this, and it's a question I put into the department around unfunded beds, and obviously there's a lot of beds, corridor beds, beds being added into wards that aren't funded, which causes great concern, and that adds into that issue around increasing risk, but also patients coming to harm. And is that something that then, you know, part of maybe some of the work that you have already done that you're feeding into the department to, you know, around what you're seeing and what the harm that is being done or the increased risk?
Yes. And give the example of it was that work in the Royal Victoria. Now it's about 18 months or more ago, but it identified all the, I'm going to say, spill out areas that were being used, all those additional beds. And I saw the Assembly question, actually I liaised on that with the Royal College of Nursing about it and engaged with Rita Devlin about the definitions of all those beds. Boarding beds, corridor beds, escalation beds, and they're not part of the commissioned programme. Look, they add increased risk in the RBH, and I hate using that one example because I am certain this is repeated in every ED, so please extend that definition beyond the area we looked at. This was a serious problem. We found several areas, ED trying to be something it isn't. ED is meant to be, as you and I know, trying to move people through the emergency part of their treatment plan, but it had become ward. It was accommodating people for days on time into these, extra beds, escalation beds, boarding beds, and so on. It adds to it. The other thing I suppose I would say is we do try to caution, and I'm saying we, colleagues, inspectors and others, also don't want trusts to feel that there aren't some actions they can take. Where you find that you do have to, just by sheer demand, have to create those additional spaces, then make them as safe and dignified as you can. So make sure that those staff that you are drawing in, it's never sufficient, but where there's locum staff or agency staff, give them time to be orientated as best you can. Increase or look at your frequency of infection prevention control, provide lockers and Cardex, and be clear on who's in charge and what's the reporting arrangements. It won't resolve the matter, but it would improve the safety of those situations, and that's what we recommended when we did those inspections before. So it's not to diminish. I think sometimes people say, you talk about improving, cleaning and safety. You're missing the point. No, we're not saying those things resolve the matter. They don't. But it's also about saying to people, while you're working in that environment, think about these extra steps that need to be taken to try to keep people safer.
Yeah. And maybe you can't answer this, but say in terms of them, whenever you're making recommendations, what sort of feedback are you getting from the department? Or, is it?
Well, our recommendations on those, go to the trust first and foremost. And what we've tried to do, and increasingly tried to do, is not to ask the trust to do something that's outside their control. And in that inspection, for example, and in the one in Craigavon, which we called it a system inspection, but there were recommendations there for both the trust and other local providers and for the department. I mean, social care reform, which I know, because I see you speaking about it and talking about it, is essential to this. It's one of the issues why we all fear these potential, issues around financial pressures might draw us all to look at areas where you can stop spending some money very quickly. And because a good part of the social care provision through nursing homes and to some extent domiciliary care